Now I'll call
Thank you,
upon
ma'am.
Dr. Chandrima. She will be talking on morphometric analysis of glaucoma, BMW MRW complex.
This mic is on, I think. Yeah, both are on now.
Both are working.
Thank you, Dr. Sunita, distinguished chairpersons. At the outset, I'd like to thank GSI and very specially the President, Dr. Satyan, for this opportunity. So I'm going to take you through the metronome in morphometric analysis of glaucoma, BMO, MRW, and posterior pole. So the optic nerve evaluation is the cornerstone of glaucoma diagnosis. And if you look at that's the picture of a donut. What we're interested in is not the hole at the center, but the chocolate on it. And that's the neuroretinal rim, which we look at in glaucoma. So here you have the actual picture where you see the neuroretinal rim. This is what we are interested in, and not in the hole out there. So morphometric analysis, striking the metronome, refers to the shift from using Brooks membrane opening horizontal rim width, that's to Brooks membrane opening minimum rim width. That's what we're interested in for assessing the optic nerve with BMO MRW, offering potentially enhanced sensitivity and a better structure function relationship. That's from the Spectralis Glaucoma Module Premium Edition, and I have no financial interest in this. So coming to the actual crux of it, the retinal nerve fiber and the astrocytes form the neuroretinal rim, as you know. But what we're interested here is this part of the story. So the RPE is above the Brooks membrane, which is above the choroid, and which is above the sclera. So what's the true margin, the boundary of the optic disc margin? So the boundary clinically, the inner edge of the sclera, we all know, is the Elschnick's ring and is identified as the disc margin, which you see in green out here. But this is according to the sclera. But clinically versus the BMO-based disc margin, if you look at that, then the BMO base, the red, is here, whereas the green with the sclera is outside. So there's a distinct difference between the two, as you see out here. So that actually raises a controversy as to which one is the actual. But putting all controversy to rest, we have Chauhan et al. Who came out with this, that since the blood vessels and the axons pass through the Brooks membrane, cannot pass through the Brooks membrane, it is the true structural boundary of the what we're looking at, of the disc. So how to find the Brooks membrane opening in OCT? So here, if you have a look at it, detect the green part, the wedge, and this is actually the Brooks membrane opening. So how to find it? The choriocapillaries cannot exist without the Brooks membrane, and so the Brooks membrane opening never ends before the choriocapillaries end, as you see out here, the internally oblique and the externally oblique ones. So in real-time scenario, if you look at it, the ending of the choroid, that is the green part of it, as we saw in the previous slide also, and this is the Brooks membrane opening. So the minimum distance between the two is this in blue, and that's what is the minimum width. So the Brooks membrane opening, if you look at it in an animated picture, this actually looks better, is that if you have the Brooks membrane opening out here, the blue line is the minimum distance, and this is the horizontal distance. So the minimum distance is actually more apt, and I'll tell you in a moment's time why it is so. So the Brooks membrane opening actually correlates with the isn't rule that we have when we follow all nomograms in the OCT. But when you're doing it, the Brooks membrane boundary, you need to be careful because it has to be regular like this, because if it has irregularity like this, then you need to check for maybe there could be a blood vessel behind which is actually causing this. So the minimum width versus the horizontal rim width, if you look at it, so here you have the BMO, and this is the minimum width that you have, and this is the horizontal width that you have. So undoubtedly, the minimum width is the more sensitive and the more correct one to use. If you look at these studies, the BMO MRW yielded higher diagnostic performance than the BMO HRW. The sensitivity of the BMO MRW was consistently higher than the RNFL and the BMO HRW. Mean deviation of the visual fields correlated better with BMO MRW. And last but not the least, the RNFL correlated better with the BMO MRW. So the Brooks membrane opening in the spectralis, if you look at it, the Glaucoma module premium edition software has 24 scan lines which detects 48 BMO positions along the ONH to determine the BMO-based disc margin. So this parameter considers the orientation of the neuroretinal rim tissue relative to the point of measurement and also takes into consideration the highly variable anatomy of the ONH between individuals and quantifies the rim width perpendicular to the trajectory actions. So here we have another interesting thing, that is additionally this software provides an anatomical positioning system where the acquisition data is based on fovea to BMO central axis, reducing the inter-individual variability as the same piece of tissue is examined every time during follow-up. So if you have a look at this, when we do not use the spectralis APS, so this is what happens. The fovea and the BMO you're seeing on the same line, but that's actually not true. When you use the app, it actually measures, and there you can see it's almost about -4 below the fovea. This also, as you see. So the FBO, the central axis is very important. So the advantage of this is that even in head tilt, or if there is a cyclotorsion, you'd get, despite all that, you'd get an anatomical position, and every time you come for examination, the same part of the segment will be examined. So if you look at the software in normal, so these are the RNFL mapping, and as you see out there, this is what the infrared image is, and there is a distance of, it's not fully aligned, it's about 1.5 degrees below. So if you look at that in 360 degrees, here we have some of the positions where you can see the difference between the BMO MRW and the BMO HRW in the entire thing. So moving to the next, in glaucoma, let us see, that was in normal. In glaucoma, the same thing follows as well. So when you actually measure the fovea and then you see the BMO, you actually get a difference of minus or plus. It's not on the same line. So this is actually much more sensitive than the previous one. So here, this was of a disc which had a thinning, and it had a temporal notch, and this is where the BMO MRW actually maps the temporal notch, and you can actually see it there. So by automatically aligning relative to the individual's the central axis at the follow-up, accuracy is achieved to detect changes as small as 1 micron in the BMO MRW. And this we've already spoken about just now. So let's have a look at what happens when it's large disc and small disc. So if you have a look at that in a large disc, if you see this, the BMO MRW, and if you see it in a small disc, is that. So this will have a large BMO MRW, whereas a large disc will have a small BMO MRW. So this actually here, the RNFL is more sensitive than the BMO MRW. So let's come to categorizing the ONH in idle situations. So in idle situations, when the clinical and the anatomical actually superimpose, then we really have no problem. But let us look at situations like peripapillary atrophy or like cornea temporalis, then what happens? So if you look at this, in peripapillary atrophy, you have the BMO here. In conus temporalis, because of the reflectivity, you could actually go wrong if you're doing a clinical size of the disc, but in the BMO MRW, there's no chance in doing that. So let us have a look at the different zones. That's the alpha zone that you see, BM and the irregular RPE present. This is the beta zone that you see, where there's the Brooks membrane present and no RPE, and this is the gamma zone that you see. So we are interested in the beta zone. So categorizing the ONH in peripapillary atrophy. So this is where the sclera ends, as you see out there, and that's where the retinal pigment epithelium ends. And this is the hyperreflectivity that is there, which could actually misdiagnose a clinically assessment of the disc margin. So categorizing the ONH in conus temporalis and PPA, that's where the RPE ends, as you see out there, and that's where the sclera ends. So this is where the BMO MRW actually measures up. This is where it is. This is the Brooks membrane opening, and that's the BMO MRW. So this is again just correlating it with what we just saw. So summary of the BMO MRW characteristics. Area influences the diagnostic precision of the BMO-MRW, but not the RNFL, mind you. If BMO area increases, diagnostic precision of BMO-MRW decreases. So this is the progression analysis. All parameters take into account this axis which we have just spoken about. And so every time your patient comes on follow-up, the same segment will be examined. So there you are gaining over the clinically assessed disc. So improving accuracy in quantitative and qualitative evaluation of the ONH, and thus creating a new world in glaucoma diagnosis. And I gratefully acknowledge Dr. Prasanna V. Ramesh, your contribution with slides and data for this presentation. Thank you very much.